So good evening once again. Welcome to this weekend's tutorial. We're looking at obstetric emergencies. All right. And these are learning outcomes. Okay, be able to define what obstetric emergencies are and how significant they are to our practice. We want to identify some common emergencies and how they present. All right, explain pathophysiology, apply evidence-based immediate management, and early recognition strategies is important. And also at the end, we should be able to appreciate the role of teamwork in managing these obstetric emergencies. So we'll follow this outline this evening. All right, we'll try to define, we'll remind ourselves about the physiology of pregnancy or the physiological changes as well as pregnancies. All right, we'll look at the classification of obstetric emergencies and see how we can deal with each and every one of them. All right, principle of management, then our case-based learning and clinical scenarios. At the beginning will be there and we will conclude. Okay, so what are obstetric emergencies? Okay, these are sudden catastrophic events that threaten the lives of both the parent and the fetus during pregnancy, labor, or in the immediate postpartum, which demand immediate action. All right, so there are sudden catastrophic events that threaten the lives of both the parent and the fetus during pregnancy, labor, or in the immediate postpartum period that requires immediate action. The leading cause of preventable maternal morbidity and mortality worldwide. Therefore, rapid early recognition and intervention are vital. In these scenarios, every minute matters for survival. Okay, so we just remind ourselves we can be talking about obstetric emergencies without looking at the physiological changes brought about by pregnancy itself. So these physiological changes are due to the metabolic demands brought on by the presence of the fetus, the placenta, and the uterus, and due also to the increasing levels of pregnancy hormones, especially those of progesterone and estrogen. So these are the causes, or these are the factors that induce physiological changes in the pregnant woman. And note that these adaptations of physiological changes affect nearly all the organ systems, all right, from head to toe, and they typically resolve after delivery. So it's brought on by pregnancy, the pregnancy state, all right, due to the presence of the fetus, the placenta, the uterus, and the increasing levels of pregnancy hormones. All right, if you look at this, you see that virtually all the organ systems are affected. We look at them one by one. Look at the cardiovascular system. Okay, so the maternal blood volume increases by approximately about 40 to 50%, reaching maximum increase during the mid-trimester. The cardiac output also increases by 30 to 50% primarily as a result of increased stroke volume and heart rate. The systemic vascular resistance decreases largely due to vasodilatation, as brought about by the progesterone hormone. Blood pressure typically decreases slightly during the second trimester and returns to pre-pregnancy levels in the third trimester. Most pregnant women, you may have systolic murmur, which is physiological, and this is a result of increased blood flow. Okay, so summary, if you're looking at all of this put together, there are 4 H of cardiovascular changes in pregnancy. Hemodilution, this is due to the increase in blood volume, all right? And then we have hypercoagulopathy because of increase in clotting factors. We have a hyperdynamic state due to the increase in cardiac output, and hypotension, the reduction in blood pressure. So just for you to remember, you can remember the 4H of the cardiovascular changes in pregnancy. Then we have the respiratory system changes. We have an increase in the tidal volume by approximately 40%. All right, this resulting in corresponding rise in minute ventilation. All right, don't forget that minute ventilation is tidal volume multiplied by the respiratory rate. So respiratory rate remains unchanged throughout most pregnancy. The functional residual capacity decreases. This is due to the effect of the diaphragm that is being displayed upward by the enlarging uterus. Or PSU2 decreases, or approximately to approximately 30 millimeters of mercury. All right, and this is due to the increase in minute volume, and this may result in chronic respiratory alkalosis. All right, there are other anatomical changes that we can see, all right, in this diagram. Okay, hematological, there's increase in blood volume, which exceeds a rise in red blood cell mass, and this is why most pregnant women are physiologically anemic during pregnancy. There's mild leukocytosis. Sorry, I need to mute that person. So there's mild leukocytosis, and clotting factor also increases, which contributes to the hypercoagulable state during pregnancy. All of this you can see, all right, on the right side of the slide. The renal system, all right, the renal plasma volume, renal plasma flow and the glomerular filtration rate all increase by approximately 50% during pregnancy. All right, serum concentration of creatinine and urea clearance as a result of enhanced clearance. Let me take that again. Serum concentration of creatinine and urea decrease due to increased renal clearance. You can have mild glycosuria and proteinuria. You need to monitor that because of increase in glomerular filtration during pregnancy. So the renin-aldosterone system of upregulation without hypertension, hyperfiltration, all right, without long-term effect, and you can have electrolytes and other acid-based disturbances, especially hyponatremia, and the respiratory alkalosis that we mentioned before due to increased minute ventilation in pregnancy. The GI also is not left without having some changes, all right? The progesterone pregnancy hormone reduces the tone of the lower esophageal sphincter, all right? This leads to increase in gastroesophageal reflux, like you can see on the right side of the screen. There is a delayed gastric emptying, especially during labor, all right? Gallbladder motility is reduced, and which may lead to increase in the risk of gallstone formation. And interestingly, there's also craving for some abnormal things. All right, these are parts of the GI changes in pregnancy. Endocrine insulin resistance increases, all right, as a result of the action of placental hormones. The BMR is also increases by 15 to 20% during pregnancy. Interestingly, thyroid hormone increases, all right, but it's actually the total tyrosine and thyroid, the T3 levels, but the free hormone concentrations appear to remain normal. There's also increase in prolactin secretions, and all of this meant to prepare the woman for the stressful state of pregnancy. Okay, so that is just a summary about the physiological changes in pregnancy. Now, so we're going to look at the first obstetric emergency, which is obstetric hemorrhage. So let's look at some of the questions. Are we ready to take some of the questions briefly? All right. A 28-year-old woman, period 2, delivers vaginally and develops heavy vaginal bleeding 10 minutes postpartum. On examination, the uterus feels soft and bulky. Okay, so number one question, what is the most appropriate initial step in managing this case?
B.
B. Do we agree? Any other? Do you all agree it's B or A? B or A?
B.
Okay.
B.
B. I agree. B is correct. I hope you are not seeing my answer in the screen. I hope the answer is not showing. Is the answer showing?
No, Prof, it's not showing.
No, Prof. No.
Okay, number 2. A 32-year-old woman, para 1, has ongoing postpartum hemorrhage due to uterine atony despite oxytocin injection. She has a history of severe asthma. Which drug should be avoided in this patient?
Carboprost. C.
B.
C. Carboprost.
C. Avoid ergometry.
I will avoid ergometrin. Carboprost is a prostaglandins analog, isn't it? So it's ergometrin. No.
She's a smart
Ergometrin
chick.
is not a problem. It's carboprost because it's a prostaglandin analog. All right. So the answer is C.
Hello,
Okay.
sir.
Hello.
Hello, Prof.
Yes.
Misoprostol is also a prostaglandin analog.
Yes. But here, I think this question a little, but I will go for C.
Why, sir?
Because carboprost has been known to exacerbate asthma attack. Okay? We can check that out. You can check that out, but I think I'll go for carboprost. Okay, we can check that out. Number 3, let's go. A 25-year-old woman with massive obstetric hemorrhage has already received 4 units of Pagret cell, aprotobin and APTT are pending. What is the most appropriate next step that you would take for this patient? Hello? Hello?
We are with you, sir.
What is talking? What's the answer?
I'll say A.
Toluwalashe Aremu, why did you say you say A?
Okay, so I feel because the patient had already been given 4 units of Paxos. So and while still waiting for because of the 4 units of Paxos may not be fresh. So we may have some consumptive coagulopathy. So we want to give some fresh frozen plasma.
I agree with you. You are correct. Correct. So you give about 12 to 15 ml per kg of FFP. Correct. All right. Number 4. A 35-year-old woman undergoes cesarean section for placenta previa. She develops massive hemorrhage unresponsive to your urotonics. The uterus is open. Which surgical procedure is most appropriate at this stage? I'm sure we must have experienced PPH in our practice. So have you been seeing what the surgeons do when, especially
B-Lynch compression suture.
B-Lynch compression suture, correct. Okay, number 5, a 27-year-old woman who had massive PPH requiring hysterectomy. After bleeding is controlled, what should be initiated to reduce the risk of thrombosis? This one has given itself out, okay. What will you do? Hello? And people are thinking.
I'll take C.
You take C?
So I'll take B.
D.
Both are wrong. Remember that bleeding has been controlled. The patient is not bleeding anymore.
D.
Each is
D.
each.
Well, won't you give your subcutaneous heparin? Is there anything against giving your heparin for this patient? Your subcutaneous heparin? Is there anything against it? And don't forget that pregnancy is a hypercoagulable state. I will give a heparin. That is your pharmacology or chemical thromboprophylaxis. All right?
Okay.
Not the therapeutic
Okay,
dose, the prophylactic dose, okay? Hello?
Okay, sir.
Okay. Now the last question. A 39-year-old man presents with severe obstetric hemorrhage due to placenta accreta. You don't want to see that, eh? It's a nightmare. Bleeding persists despite ureteronics, balloon tamponade, and vessel ligation. What is the most appropriate definitive intervention here?
Hysterectomy. D.
D.
Hysterectomy.
Correct.
D.
Hysterectomy. You need to get that uterus out. Correct. Okay. All right. So massive obstetric hemorrhage is a major cause of maternal morbidity and mortality worldwide. But the high hemodilution, the relative hemodilution, high cardiac output, all right, occasioned by physiological change in pregnancy, allows substantial bleeding to occur during labor before a significant drop in hemoglobin concentration. However, some comorbidities associated with pregnancy can contribute to the occurrence of catastrophic bleeding, especially with consumption coagulopathy, all right, which makes this situation worse. Okay, so massive obstetric hemorrhage is defined as a loss of more than 2.5 liters of blood in the peripartum period. It also refers to a drop of hemoglobin concentration of more than 4 grams per dl requiring the need to transfuse more than 5 red cells, or the need to treat coagulopathy or perform invasive management procedures. All right, so the second definition kind of highlights the different scenarios that can be defined as obstetric hemorrhage. Okay, so obstetric hemorrhage can be caused by different factors. Okay, it can be antepartum or postpartum. Let's look at antepartum hemorrhage. All right, this is defined as bleeding from or into the genital tract after the age of viability, okay, and before the birth of the baby. So bleeding from or into the genital tract after the age of viability, okay, there is more than 20 to 24 weeks gestational age, and before the birth of the baby. Common causes are placenta previa, all right, different types. It can be complete, partial, marginal, low lying. All right, placenta abruptio, 30 to 40%. All right, and the problem of placenta abruptio is that the bleeding may be concealed. Okay, so high index of suspicion is very important. Local causes like cervical lesions, vaginal trauma, infection. All right, when fetal vessels transverse membrane over the cervical os can lead to rupture causing fetal insanguination. All right, and this can be a cause of APH. Unfortunately, about 30% of them of APH may be due to unknown causes. So what are the management principles? Every patient, every woman with unexplained antepartum hemorrhage must be admitted in high dependency unit. And high dependency unit does not mean that it must come to ICU. All right, the maternity ward itself, the labor room, is a high dependency unit. I remember those days in UBTH, we used to have HDU in the maternity ward. I mean, in the labor ward rather. So you assess and stabilize the mother first. The mother comes first, and assess for IV access, resuscitate with crystalloids and or blood, depending on the degree of the bleeding. And you want to monitor vital signs, urine outputs. Anti-shock measures should be instituted, and you want to continuous fetal monitoring. All right, so placenta previa is one of the common causes of APH. All right, and as you can see in the diagram of the picture on the right side of the screen, okay, so placenta previa may present either with minor or major bleeding, okay, and the minor bleeding, preterm mother and fetus is stable. So in this patient, you want to admit the patient for bed rest. And if the patient is, if the fetus is less than age of viability, you want to give your steroids, all right, for long maturation and wait for appropriate time of delivery. However, if the bleeding is major, all right, resulting in either maternal or fetal compromise, you want to deliver the patient immediately by cesarean section. Obviously, you don't want the patient to go through labor. Okay, placenta abruptio, all right? In this group of patients, you want to stabilize the mother, correct the shock, and placenta abruptio is actually one of the predisposing factors for coagulopathy. You want to watch out for coagulopathy. Now, if the fetus is alive from your fetal monitoring and mother is stable, you want to expedite delivery, okay? But if the fetus is dead, vaginal delivery is indicated, but you need to watch out for bleeding, especially consumption coagulopathy. All right. So the second cause of obstetric hemorrhage is postpartum hemorrhage. And this is where most of us as anesthetists and critical care physicians come in. Most of the times for APH, placenta previa is really maybe due to emergency cesarean section. For postpartum hemorrhage, we I have a lot to do here as perioperative physicians and critical care practitioners. So PPH could be primary or secondary. All right. So primary PPH is when there's a loss of 500 ml or more blood from the genital tract within 24 hours of the birth of the baby. So it could be minor when you have between 500 to 1,000 mils, or major when you have more than 1,000 mils of blood loss. All right. So major can also be divided into moderate and severe. So when you have a bleeding, blood loss of more than 2 liters is severe. All right. But note that women with lower body mass, especially those who are less than 60 kg, a lower level of blood loss, it may be clinically significant. So we're not just looking at the numbers. Okay. So secondary PPH is when the abnormal excessive bleeding continues from the birth canal between 24 hours and 12 weeks postpartum. Okay, so primary and secondary PPH are very, very critical causes of maternal morbidity and mortality. The Society of Obstetrician Gynecologists of Canada summarized the causes of PPH, all right? So we have the 4 T's, the tone, trauma, tissue, and troponin. All right, but know that the most common cause of PPH is uterine atoning. Okay, and you can see some of the risk factors here. So when we have a patient with multiple pregnancy, the common cause of PPH will be uterine atoning. So you deal with a tone. Patient will have previous PPH, all right, tone, uterine atoning. Preeclampsia, this is coagulopathy, all right, trombone problems. Fetal macrosomia, failure to progress, this is a tone, but patient will retain placenta accreted, this has to do with tissue. Okay. Episiotomy, especially I remember those days when we were doing house job so many years ago. We had cases of episiotomy leading to PPH, perineal laceration, and general anesthesia, especially for patients who you're giving, under general anesthesia, giving so much halotane, all right? You can cause loss of tone, uterine atoning, all right, as a cause of PPH. Okay, so this is just that diagram to show uterine atoning about 70%, trauma 20%, retained tissue, and troponin. Okay, so how do you manage PPH? Number one is to identify the severity of the blood loss. This is important. Okay, you must be able to identify the severity, how much blood loss, what hemodynamic compromise has ensued. So number one, visual estimation of the peripartum blood loss vis-a-vis the clinical signs and symptoms. All right. More accurate methods to include blood collection drapes. You want to look at the drapes and the weighing of swabs. Okay. Clinical signs and symptoms of hypovolemia, all right, should be included in the assessment of PPH. But note that any patient bleeding with a systolic blood pressure less than 80, as well with worsening tachycardia, tachypnea, and alternated status, this should indicate or point towards PPH, especially with a blood loss of more than 1.5 liters. So a patient who is hypotensive with systolic blood pressure less than 80, there is tachycardia, tachypnea, and alternated status. This patient most likely would have lost above 1.5 liters of blood. So identification, okay, of severity of blood loss is very important and is the first step in the management of PPH. All right. Number two, communication. This shouldn't come last. It should be early, clear communication with the patient and her partner is essential from the start. We're having some issues, your wife is bleeding. All right, multidisciplinary team involvement. This is not the case for junior residents or senior house officers. All right, the most senior member of the team, starting from the consultant of both teams, either this should include the obstetrician, the anesthetist, the hematologist, everybody. Okay, dedicated team should record events. All right, fluid, drugs, blood products, and vital signs for the management. So important, is very important. Communication and multidisciplinary care is very crucial in the early management of PPH. Okay, so we follow the APC approach. Okay, all right, you want to look at the airway, the patient, the airway patient. All right, always remember that the airway of a pregnant patient is deemed to be anticipated difficult airway. Okay, so breathing, all right, and does the patient require supplemental oxygen? Obviously, most of them will do, and circulation, okay, in terms of getting IV access. So position the patient flat, all right, and keep her warm using appropriate available measures. And this is important because hypothermia can actually worsen coagulopathy in a patient that is bleeding. Okay, so you want to transfuse blood as soon as possible, and that is why clear communication multidisciplinary team comes in. Right, I remember a lot of times those days how we used to run between the blood bank and the theater, trying to get as much blood as we can. While you're waiting for blood, don't fold your arms. You can give up to 3.5 liters of warm clear fluid. Initially, you will start with 2 liters of warm acetonic crystalloids. All right, the other 1.5 liter you may want to use colloid if you're still waiting for blood. But note that you want to avoid hydroxyethyl starch, all right, because it also affects your coagulation status. Note that you want to rapidly transfuse blood. So all those blood-giving cells with special blood filters should be avoided because they tend to slow your transfusion. All right, and more importantly, instead of using a central line in this patient, you want to use a large bore 14G. All right, so for rapid transfusion, I avoid the central line because the triple lumen catheters are small, the caliber diameter. So you want to use a 14G because here time is of essence. You want to get as much blood back to the patient. All right. Oxygen, like I mentioned, should be given high flow, about 10 to 15 liters, and this will also increase the oxygen carrying capacity of the blood. Okay, you are giving blood oxygen to the limited amount of blood that is available, so you are increasing the oxygen delivery. All right, so the tissues. Fluid resuscitation is essential. All right, but note that you have to be careful because excessive crystalloid above 3.5 without adequate FFP and platelet will induce dilutional coagulopathy, worsening the bleeding. All right, I mentioned about 3.5 liters may be given, but note that, like I mentioned, the speed and the warming of fluids are more critical, all right, than the type of fluid you're given, because apart from hypothermia inducing coagulopathy, it can also worsen acidosis, metabolic acidosis in this patient. The WHO recommends isotonic crystalloids of colloids, but a Cochrane review has not shown any benefits, all right, with colloids, okay? And hydroxyethyl starch may actually worsen mortality. So I would like to stay with crystalloids all the time. And early coordination with the blood bank will reduce the time waiting for blood to arrive. So blood transfusion, 14G, 14G IV cannula, all right? You immediately also will send blood samples, okay, for diagnosis, take your full blood count, coagulation, screening, and all that, okay? And you want to get compatible blood to replace red cell loss as soon as possible, okay? But note that the main therapeutic goals of managing massive blood loss, especially obstetric blood loss, is you want to maintain your hemoglobin above 8 grams per DL. Okay, platelet count should be greater than 500 testosterone at 9 per liter. Your prothrombin time should be less than 1.5 times the normal, and your APTT should also be less than 1.5 times the normal. All right. All you're trying to do is get fibrinogen greater than 2 grams per liter. So this is your therapeutic goal. All right. A lot of times we don't have to get HB of 10. All right. You want to achieve, if you can get 8 grams per DL, all right, and you get the other platelet count greater than 500. With all these other parameters, this should be the goal of managing massive obstetric hemorrhage. Yes, intraoperative salvage, especially in our environments, sub-Saharan Africa, where we have limited blood supply, all right? The patient's own blood can be salvaged, all right? You can see, and, collected, filtered, and washed in a salvage machine and re-transfused back to the patient. All right, the beauty of it is that it's autologous blood, so the risk of blood transfusion reactions, clerical errors are reduced, okay? And it has not been shown to have any adverse effect on clinical outcome. Actually, I've been involved, all right, in many cases where we had to do this. And sometimes when you don't have the blood salvage machine, what we have done is to just use gauze, all right? I hope by now we should have self-salvage machine most of our centers. But if you don't have, and you don't have your blood coming from blood bank, okay, they'll collect the blood, all right, with aseptic technique, and they'll filter the blood through your gauze. We've done that many times, and we transfuse the blood to the patient, all right? It's been suggested, all right, for emergency use in PPH. All you're trying to do is get the patient blood and restore the patient's blood volume, okay? No serious maternal complications have been linked to this use, especially if you have a self-salvage machine in your center. But if you don't have, don't hesitate to use the patient's own blood, all right, intraoperatively to retransfuse the patient with blood. Okay, so after, this is the question we asked earlier on. So after you have transfused 4 units of packed red blood cells, the next thing, you don't have to wait for coagulation results. You should transfuse fresh frozen plasma, all right, at a rate of 12 to 15 mils per kg. Okay, early use is recommended, especially in patients with risk factors for coagulopathy, the patients with placenta abruptio, amniotic fluid embolism, or patients with delayed recognition of PPH. All right. So, and make sure that your prothrombin time and APTT is more than 1.5 times normal, especially with ongoing bleeding. All right. People have talked about the ratio-based protocols. You give 1 red blood cell, you give FFP. Some people have talked about 4:1. But whatever it is, there's no clear evidence of benefit in PPH. You want to just give as much packed red blood cell and give FFP to reduce the risk of coagulopathy. Okay, so management of PPH, we have different types. Mechanical, all right? The idea is to arrest bleeding. So mechanical bimanual uterine massage, all right? This is to stimulate uterine contraction. And don't forget what we said earlier on, that uterine atony accounts for more than 70% of the causes of PPH. So by manual uterine massage, all right, to stimulate contraction, all right, uterine balloon tamponade, and manual reduction of uterine infarction, especially if this is a cause of the bleeding. All right, pharmacological, so you come, all right, come carboprost, oxytocin, misoprostol, and egobentrine, all right? So you avoid carboprost in asthmatic patient, you avoid, or you give egobentrine with caution in patients with hypertension, okay? So initial dose of oxytocin, you want to give 10 international units, all right? IV or IM slowly as the case may be. And you can also do subsequent, you put 10 to 40 units in 1 liter of normal saline, all right? And you start at 10 to 4 ml per minute. And I titrate to achieve and maintain uterine contractions. All right, carboprost 0.25 milligram IM, all right? And with a maximum dose of 8 doses. Be careful in asthma. Misoprostol per rectum can be used, and egobentrine 0.2 milligram IM. You can repeat this every 2 to 4 hours. So the mnemonics is calm, carboprost, oxytocin, misoprostol, and egobentrine. All right, surgical intervention. All right, if all of this fails, your mechanical, your pharmacological intervention fails, all right, you want to surgical intervention. Okay, so first line intrauterine balloon tamponade, okay, preferred over uterine packing. I remember those days, even up to now, I still see some patients come to IC with a lot of uterine pack in PPH. All right. B, Lynch hemostatic sutures, especially after cesarean section. Vessel ligation. I remember, I don't want to mention his name, very, very proficient obstetrician. We've done a lot of internal iliac artery ligation, all right, especially in patients with PPH that are not responsive to other modalities of treatment, and especially if the patient is a primate. So internal iliac artery ligation, all right, if all fails, especially for patients with placenta accreta, pancreata, all those ones that the placenta has, you know, what's the word now, has infiltrated the uterine, the uterus, all right? So there's no way you can get those placenta tissue out, hysterectomy, all right? Or patients who have had the uterine rupture, hysterectomy becomes the definitive way, okay? Temporary major aortic compression to buy time for resuscitation and surgical support. Okay, monitoring is important. All right, this patient, even after you've secured hemostasis, this patient requires very attentive monitoring, full blood count, especially coagulation screen, which should include your fibrinogen. All right, and monitor temperature every 15 minutes, just to be sure that your patient does not become hypothermic.